Sorry, actually, I was not free this weekend, so that's the reason I thought I'll do the free session today. Can you see the case, doctor? Can you see the case?
Yes, sir.
Okay, okay. You are ready, doctor?
Yes, sir.
Okay. I'm going to keep the timer here. You know how to divide the time, isn't it? 8 minutes for history, 5 minutes for examination, 2 minutes for addressing patient concerns.
Yes,
I'm
sir.
not going to stop you at 8 minutes. It's for up to you to decide whether you have finished everything in 8 minutes. If you go beyond 8 minutes, that's left to you. You will get 13 minutes to do both history and examination. Okay. I'll
Okay.
keep the
Okay.
timer on screen and you can keep looking at the timer. Okay.
Okay, sir.
Yes, doctor. Yes, your timer has started. You can start.
Hi, good evening. I'm Dr. Karpuswamy. I'm one of a doctor in this clinic. Am I speaking with Mr. Satish, 26-year-old?
Yes, doctor.
Okay. Hi, Mr. Satish. Today we are going to discuss about your health condition, in which I'm going to ask you some questions and followed by examination. Is it okay for you?
Yes, doctor. This is how your
Okay.
patient looks. You enter the room and you see the patient. Yes.
Okay. And Mr. Satish, are you comfortable right now? Can we proceed?
Yes, doctor.
Okay, okay. Uh, I came from the notes that you are having some dizziness. Can you please elaborate for me, Mr. Satish?
Doctor, since few days I feel dizzy. For
Okay,
example, I'm sitting on a chair, I get up suddenly and I start feeling dizzy.
okay, okay. Few days in the sense, like, can you tell exactly how many days it was?
1 week.
1 week. So you are experiencing the symptom for the first time, or you are already having this symptom before?
I never had this dizziness.
Okay, okay. So you are feeling dizziness all the time, or only during the time of work or getting up from a sitting position, Mr. Satish?
Mostly when I get up from sitting to standing position, doctor. Even when I'm lying down, when I try to get up, though getting up is difficult for me. When I try to get up, I feel dizzy.
Okay. Do you have any during the time? Do you had any fall?
No,
Okay. And so, how you to get rid of this dizziness, Mr. Satish? How will you get rid of this?
I don't know how to get rid of this.
Okay, fine. Do you have any headache?
No, no headache.
Okay. Do you have any vomiting?
No,
Okay. And do you have any raised body temperature in these recent days?
no,
Okay. Do you feel any different in your vision?
no,
Like you are feeling any double vision, or you could not able
no,
to see properly?
no,
Okay. Do you ever had a history of accident before, Mr. Sadish, in the recent past?
no.
Okay. And do you noticed any weakness involving your body parts, like in your hands or in
Yes,
the upper limb or on the feet?
yes, doctor. In fact, I see that my weakness is worsening.
Okay. Can you exactly describe where is the weakness was, whether it is in your legs or in the
Weakness in my
hands or
leg,
in the face? Sorry, I could not
in
able
my
to hear you.
legs, in my legs.
Okay. It is in the both the legs or in the only in the one leg?
It's in both the legs, but worse on my left leg.
Okay, so is there any problem with your sensation, Mr. Sadish? Do you feel all the sensation, or
I'm not
do you
sure,
feel
doctor.
any?
I'm not sure,
Sorry.
doctor.
Okay, okay, okay. Do you have any abnormal movements involving the body parts?
No,
Okay, and do you have any problem with using your upper limbs, Mr. Sadish, like doing combing or anything like that?
no,
Okay. Do you have difficulty in swallowing or eating foods?
no,
Do you have any noticed any changes in your speech?
no,
Okay. And do you have any cough during taking liquids, so tea, coffee, or water?
no.
Okay, fine. Do you have pain anywhere, Mr. Satish, in the legs?
Yes.
Okay, can you
I got
describe
pain
where
everywhere in
exactly?
my hands, in my legs.
Okay, fine. And do you have how is your water works?
Water works are fine, doctor.
Okay, how is your bowel works?
Bowel works are fine. In case my network
Okay.
get disconnected, let me know, doctor. If at all you won't hear
Yeah,
me
yeah, yeah,
properly in between, let me
yeah,
know. Okay. Okay.
yeah, yeah.
Yeah,
Do you have
continue.
do you have any back pains?
No back pain.
Okay. Do you ever lost your consciousness, Mr. Satish, in
No.
these days?
No.
Okay, fine. And do you notice any lumps and bumps anywhere in your body?
No.
Do you have any chest pain or raising or passing of your heartbeats?
On few occasions, I have seen that my heart is racing faster.
Okay, fine. Do you have a cough?
No.
Okay. And do you have any joint pain or notice any rashes in your body?
Joint. I get pain in general in my joint, in my muscles. It keeps aching.
It is aching.
Yes.
Okay. Okay. How long it was there?
It's there most of the time, doctor.
Okay. Okay, fine. Okay. Do you notice any color changes in your urine?
No,
Okay. Do you notice any weakness in all your face?
no,
Okay, fine. And Mr. Sadish, what are you doing for your daily living?
I don't work.
Okay, okay. I'm sorry to hear that. And whom are you staying with you?
I live with my family.
Okay. And do you have partner? I'm going to ask you some personal question. Is it okay for you, Mr.
No.
Satish?
Yes.
Do you have any partners?
No.
Okay. And do you have any previous medical problems like sugar or blood pressure or any fits or anything like that before?
No.
Okay. Do you underwent any procedures or surgeries in the past?
No.
Okay. And do you take any medications?
No.
Okay. And do you use any recreational drugs, Mr. Satish?
No.
Okay. And do you smoke or consumes alcohol?
No, I don't.
Okay, fine. And do you have any allergy to any medications?
No, doctor. Not that I'm aware
Okay.
of.
Okay. Okay. Have you been traveled recently anywhere else before?
No.
Okay. Uh, fine. Does any one of your family members have blood pressure or sugar or any other problems like this?
No. It is only me, doctor, with all this problem in my legs.
Okay. And Satish, I want to know you don't have weakness before, right? You are having only for these past days, right? You don't have this weakness before.
No, the weakness I had before as well, doctor.
Okay. How
I've
long you
got this
had?
weakness since my childhood. It's only getting worse.
Okay. 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 Fine. Uh, do you have any vaccination recently, Mr. Satish?
No.
Okay. Fine. And Satish, I think do you travel? Do you drive?
No, doctor, I don't drive with my legs like this. I don't think I
Oh,
can drive.
okay, okay. Sorry, Satish. I think till the further assessment, I don't want you to drive, like because it might be harmful for you. Is it okay?
Okay, doctor.
Okay. And the other thing also, I want to say you are having some dizziness also, and that will be also harmful for
Mm-hmm.
getting driving. So I would
Mm-hmm.
like you to stop driving. Okay.
Sure.
Okay. So examination.
Yes, doctor, go ahead.
So I start with the general physical examination. I will look for his upper limb. Is there is any pallor involving the nail beds or any pan-digital clubbing?
No.
Any
No
abnormal
clubbing.
movements involving the upper limbs?
No abnormal movements.
Any wasting involving the small muscles of the hand?
In hands, no.
Okay. So in the vitals, or the vitals are same as given in the chart
Yes.
previously.
Yes.
Uh, okay, so I want to check for orthostatic hypotension. Is there is any evidence of orthostatic hypotension, sir? Then I will check the patient supine, and after standing, I will check at 0 minute and third minute, sir. Is there is any change in the
No.
systolic and diastolic blood pressure?
No.
So is there any change in
Hey,
the heart rate?
there's no postural drop in his blood pressure.
Okay, is there any change in the heart rate, sir?
No. Same.
Okay, okay. So any evidence of pallor, sir, in the conjunctiva?
He's pale.
Okay, sir. Any icterus?
No.
Okay. Sir, how is the facial symmetry? Is it also okay?
It's symmetrical.
Okay, so fine. And is there is any lymphadenopathy in the neck?
No.
And is there is any swelling in the anterior aspect of the neck?
No.
Okay, so fine. So how about is JVP?
JVP is not elevated.
Okay, so fine. So is there any pedal edema?
No pedal edema,
No,
doctor.
no, pedal edema was not there. Okay, so fine. So I will start with the central nervous system examination, sir. I will check the power of his lower limb, sir. I will start with examining the power of the hip,
Okay.
the
How
knee,
is
and
low?
the ankle, sir. Left side and right side.
Okay, you can see the video. This is how his lower limb looks. Yes, doctor, this is your inspection.
Uh, 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 Okay, sir, fine. Sir, power, sir, power.
Power, what
Sir,
group of
power in the
muscles
hip
you
and
want
the
to
knee
check?
and the ankle, sir.
Okay, so in the right side, the power proximal is 4 by 5,
Okay, sir.
distal is 4 by 5. In the left, it's 3 by 5 proximal, 3 by 5 distal.
Okay, sir. Sir, I will check for the pinprick and vibration sensation, sir, in the lower limb. I will start from distally and I will move proximally. Is there is
Pin
any
and vibration both are intact,
both?
bilateral.
Oh, okay, sir, fine, sir. So I will look for the dependent jerk, sir, in the lower limb. That is knee jerk and ankle jerk.
Okay. The reflexes are reduced in the right knee, and in the left it is absent.
Sir, plantar, sir. What about the plantar?
Plantar on the right it is down going. In the left it is mute.
Sir, is there is any clonus, sir?
There is no clonus.
Okay, sir. What about the tone?
You can check here, doctor.
Okay. Mr. Satish, do you have any back pain before?
No.
Okay. Sir, I'm observing almost like whitish patches in his legs and the limbs,
Mm-hmm.
right? Mostly they are vitiligo patches.
Mm-hmm.
Uh, sir,
Yes, doctor.
I want to know if there is any family history of any autoimmune disease in his family. By
No.
chance, he knows.
No.
Okay.
Anything else you want to examine?
Sir, I want to examine for the coordination, sir. Is it okay in the upper limb? I
He's
think lower
unable.
limb I could not able to examine, sir. Coordination,
Coordination seems to be intact on the right lower limb. Left leg he can't do it because of the weakness.
sir, in the upper limb it is intact, sir.
Intact.
Any nystagmus or any extraocular movements abnormality?
No. So you're left with 2 minutes. Move to patient concerns, doctor.
Uh, yeah, yes, Mr. Sadish, what do you want to know?
Doctor, what's going on? Why do I have this weakness? Why it is getting worse? Why I'm having dizziness?
Actually, Mr. Sadish, after asking these questionnaires and examining you, I think most probably like you might be having a problem, nerve problem in your problem with the nerves or muscles in your left lower limb. That is the reason for the weakness. And other thing is, on examination, you are found to be very pale. That is, you might be having a low blood levels. That might be reason for your dizziness. That the weakness in your leg, which he may need further investigations, and we'll let you know.
So you don't know why I'm having this weakness and this dizziness. What needs to be done for this, doctor?
Actually, Mr. Sadish, we are going to do some set of investigations and imagings which are only necessary. And uh, after that investigations, we'll let you know like what exactly happening with you. As far as now, you might be having a problem with the muscles in your left leg, Mr. Satish. Yes.
Okay. So do I need to be in hospital for a long time, or can I go home?
No, Mr. Sadish, we want you to admit you, and we have to so do some extra investigations also, and definitely you have to be admitted.
Okay. Okay, doctor. So your time is done, doctor. 15 minutes are
Yes,
done. Now examiner's question. Can you
yes,
give me just your positive findings? Only the positive findings, doctor.
sir. Sir, pallor is there,
Okay.
and multiple whitish patches which is scattered throughout his body, and which is predominantly over the peripheries, that is on the elbows, hands, and foot, and the knee.
Okay.
And Sir,
So
he
your
is,
findings.
yeah, yes, sir. He is, uh, 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 so he's having predominantly having element type of lesion involving his left uh, lower limb, sir.
Okay. Lemon.
Yeah, yes, sir.
Okay. Fine. What findings did you get to tell it as a lemon, doctor?
Sir, actually, the first thing, the power is reduced, sir. That is the one thing. He's having a hypotonia, and the deep tendon reflexes are absent. And sir, his sensation is sorry, is plantar is mute, sir. So these things point towards he might be having a lemon lesion.
Any other findings did you elicit, doctor, in the lower limbs? Anything else? On inspection, on examination, anything
Sir,
you
there is an
suspected?
atrophy, sir. Actually, sir, there is an atrophy involving his left lower limb, sir. Almost muscles are get atrophied.
Mm-hmm.
Sir, and the thing is, in the history, he's having, he's saying this is illness is almost for the past since childhood, sir.
Mm-hmm.
So mostly, most probably,
Give me
it
the
might be
findings,
wrong.
doctor. Give me the
Yeah,
findings. Is there
yeah.
anything else? Findings.
Uh, sir, actually, I could not able to appreciate, but there is some deformity involving his foot, sir.
What deformity, doctor?
Sir, uh, it is a pes cavus type, sir. Yes,
Where, doctor? Pescavus?
on the left foot, sir.
On the left foot.
Yes, sir.
Anything else?
And also the ankle joint is little bit plantar flex, sir. That is the other finding I could able to appreciate.
Plantar flexed ankle joint.
Yes. Yeah. Yes. Yes.
Okay. Right. So with these findings and with the history, what differential diagnosis would you give here, doctor?
So first differential I will offer for him is an poliomyelitis sequelae, sir, post polio residual paralysis of his left lower limb.
Mm-hmm. What else, doctor? So you think it is patient has got post polio syndrome?
Yeah. Yes, sir.
Okay. What else? What are the other differentials?
Sir, other thing is he's having anemia and vitiligo prejudice. I will suspect an underlying autoimmune polyendocrine syndrome, sir.
Autoimmune
Coexisting
polyglandular
polyendo,
syndrome.
yeah, underlying polyendocrine syndrome, sir. Yes, underlying.
Okay. What else, doctor? Anything else? Why do you think this patient has got dizziness?
Sir, mostly due to anemia, sir. That might be the reason.
Mm-hmm. Okay.
Sir, and sometimes the patient, other thing is porphyria, sir. That is other differential for him.
What porphyrias, doctor?
Sir, it is,
Okay. Any
sir,
other differential? Any other differentials, doctor, apart from this?
sir, lead poisoning, I will add, sir. Yeah,
Lead poisoning.
yes, sir. Yeah.
Okay. Fine. So how do you manage this patient, doctor?
So first, I will educate the patient, education and counseling about the clinical condition of the patient. First, I will ask not him to drive since it is very harmful to him, and I will refer him to now doctor for complete clinical assessment, and I will start him on physiotherapy, and I will start. I will advise him for occupational therapy for this patient.
Mm-hmm.
Uh, so then I will go with the imaging, sir. That is the first thing I will do. I will do a CBC, complete blood count to look for hemoglobin, and I will do a peripheral smear, sir, to look for the type of anemia. And for specifically in this patient, I will do an since he's having suspecting autoimmune diseases, I will do intrinsic factor antibodies in this patient, sir. That is that thing I will add. And the other thing I will do is, and I will do electro nerve conduction study, and I will do electro EMG study, and uh, I will do imaging of the lumbosacral spine, sir. MRI of the lumbosacral spine to look for any other localized causes.
Mm-hmm.
Then I will screen for him for
Okay, doctor,
diabetes,
we'll
sir. I
stop
will
here. Okay,
HbA1c and
okay,
fasting blood
okay,
thyroid.
okay, doctor, fine. So you have done well. Okay. So just first let me give you the marking.
Yes, sir.
You can see the screen, right?
Yeah, yes, sir.
Okay, so I'll tell the diagnosis is a post-polio syndrome. Okay, we'll come to that. Your
Yes,
physical examination, I would give you a satisfactory. Identifying physical signs, okay, I would give you satisfactory. Communication, I would give you borderline. DD, I would give you borderline. Clinical judgment, again, you would get satisfactory. Managing patient concerns, I would give you completely unsatisfactory. I'll tell you why. Managing patient welfare, again, you might get full. So you would score around 20 out of 28. Okay. So even though you get your diagnosis right, you will still end up failing one of the skill here, like patient concerns. Okay. I'll tell you why. So we'll discuss about the case. Okay. So first let's go to the findings. Okay. So let's go through this video first. Okay. What do you see here? Okay. This is mute planter. Okay. Give me a second. Okay. Let's see this video first. Okay. What do you see, doctor, on inspection? You see, you told about hypopigmented patches.
yeah, yes, sir. Yes, sir.
Okay, where are these hypopigmented patches? See the distribution. Where are they?
Sir, usually in the periphery, sir, below the ankle joint, sir, it is more, or in the lateral aspects.
Okay, and you are telling about the vitiligo. So do they follow any patterns? Vitiligo patches.
Yeah, yes, sir. I think there are some specific patterns are there, sir. Acral vitiligo is one of the entity.
Okay, okay. So here, if you see on the left side, it's there on the lateral malleus and in the lateral part of his foot, isn't it? Even on the right
Yes,
side, if it is there on the lateral side. Okay, and even in the hands, it is there on his dorsum, isn't it?
yes, sir.
Okay. And if you see, it's there over his knees as well, right?
Yes, sir.
Okay. So I'll come to that. Why you are seeing this? What are these hypopigmented patches? Now, other than that, what else do you observe?
But
What do
actually,
you
on the
observe? Like,
sir, on
what
the right side, there is an hypertrophy is there, sir. Muscle hypertrophy is there. Calf muscle, little bit.
it is not hypertrophy, doctor. It is wasting on the left side. That is why you are
Right?
seeing it as hypertrophy on the right
Hypertrophy.
side. Okay,
Okay,
there is
sir.
no hypertrophy on the right side. So,
Fine,
see,
sir.
any chronically ill patients, when they're having this weakness, it's the chronic long-standing weakness. Why would they have hypertrophy? They'll have atrophy, isn't it? Disuse atrophy, right? So you've
Atrophy.
got a
Yes.
muscle wasting. If you see that asymmetry, that's where your diagnosis is.
Yes,
You
sir.
need to observe. Inspection is everything here, right? So there is definitely asymmetry in his both legs, right? The left one seems to be having lesser bulk than compared to the right. So there's definite wasting on the left side. Then what else do you see?
The shortening is there, sir.
Exactly. There is limb shortening, isn't it?
Yes, sir.
There is limb shortening on the left side, right? And do you see this arch on the left, right?
Yes.
Yes. So there is pes cavus on the left side, right? And you have already told me about the hypopigmented patches, right? So on inspection itself, you have got three findings: limb shortening, wasting, and there is pes cavus, right? Okay. Then I gave you the reflexes which are all reduced, plantar's mute, and there is hypotonia here, isn't it? If you see on the left, see, That is definitely a hypotonia, isn't it? Compared to right. Okay. See the right and left. Definitely it is hypotonic on the left side. So that is your one more finding, isn't it? Hypotonia. Okay. Then the reflexes were absent or reduced on the left. What happened to the sensory? You examined only for the pinprick and vibration. A case like this, ideally, you should examine all the four sensory modalities because that is expected from you, because that will help you to localize the lesion and also help you to tell you about the differentials. Okay, all four sensory modalities were normal in this patient. Okay. Right. And in the history, what was missing was the story. Okay. See, always it is about the story. Okay. You missed a bit in the story. How did it start? When he tells you that it has started since his childhood, you need to know since when. What age were you when you had this weakness? So, what happened? You need to know the event, isn't it? What happened that made this weakness come, right? There can be something, right? That's how you will know the cause, right? So you got a bit carried away. I'll tell you the mistake. You got a bit carried away initially when you saw the patient because you had seen the symptom of dizziness. You were expecting something else, and you saw a neurological case. So don't get carried away. Okay. So be confident. Okay. This happens in your real exams. Okay. They cannot just tell you that unilateral leg weakness. If I tell you, you will know your diagnosis, isn't it? So they try to trick you, see how you would manage, how you would handle yourself in the tense situation. So they do that in the exam, so you got to be ready for everything. Okay. Then you good that you ruled out all the neurological symptoms when you saw this patient. Okay, and always observe your patient. Look for signs when you take history. Keenly observe. Okay, if you get the diagnosis, you can take a much more accurate, proper history, which the other candidates might fail to do so. Okay, always keep looking for clinical signs when you're looking at the patient. You covered past medical history, you covered drug history, you covered allergic history, you covered travel history, family history, good, and you also covered driving. That was a very important thing here. Okay, why would you want to examine JVP, doctor, on examination? I have told you, do not do JVP anywhere other than your cardiology examination. For God's sake, do not do JVP anywhere, not in any other systems as well in your clinical stations. It is not going to add you any extra information or any other, it will not help you to give any other different differential diagnosis. JVP only in cardiology station. If it is absolutely required, you are dealing with a right heart failure and you can already see the pulsation in the neck, that time, yes. Or in the end, when you have got enough time and you think it is very relevant, then you can go ahead and do it. Because if you want to examine for JVP, you have to put the patient in 45-degree. Do we have the time to go if the patient is lying down in supine position? Do you have the time to go put the bed in 45-degree and go and examine him again? Do you have that time in exams? No, right? So follow the proper sequences. Okay, there's a lot of wrong sequencing that has been taught to the candidate. See, what is required for the paces is what you need to do. Okay, so all the videos which are uploaded, it is what is expected from the paces candidate. That is what we teach here to the IMTs. Okay, that is what we teach here to the IMTs, and that is what is expected from you from the paces candidates. Okay, or follow the right sequence. Okay, try and go through all the videos and all the sequences that is there in the YouTube. Okay, now coming to this case, so it is a poliomyelitis bit. I will brief you about poliomyelitis, then I'll speak about the differential diagnosis here, then we'll speak about the hypopigmented patches that you saw. Okay, so poliomyelitis will always have a 4 to 5 stages. Stage one is the prodromal phase, where initially, which is a non-paralytic phase, which lasts for 1 or 2 days, where the patient will have flu-like symptoms or a GI symptoms. It can be fever, sore throat, headache, or any GI symptoms. Then next is they go into a paralytic phase that happens in the next 2 to 5 days, where it will always have an acute onset. It will be asymmetrical and proximal weakness more than the distal. Very important. Okay, this is the same pattern that you see even when it evolves later. So in the paralytic phase, which happens in 2 to 5 days after the infection, patient will have acute, sudden, proximal, asymmetrical weakness in the lower limbs. Okay, and they would describe it as refusal to walk or floppy limb. Okay, then comes is a recovery phase. Okay, so most of them recover from this in about 3 to 5 days. Okay, on few occasions, the recovery phase might go up to 6 months. If the recovery phase goes for more than 6 months, then it is a residual phase. In that case, it will be a permanent weakness. So if it goes beyond months, then it will be permanent weakness and the patient start developing all deformities. Polio is a very important case for your exams because there are many polio cases, because it is very easy for all the exam centers to follow up these cases. They're all chronic cases, isn't it? They won't be acutely unwell, and it's easy for them to catch hold of these patients and they'll come for the exam hall. Okay, so every center has got a good polio case, and when they ask you about polio, if it is a polio case, they might ask you these questions, so you need to know. Okay, then they go into the next phase, that is your post polio syndrome. What is post polio syndrome? So this patient has got a post polio syndrome. What happens in post polio syndrome? So once you get this polio and infection by this poliomyelitis, you get this inflammation or the infection in your motor neurons. So over the decade, what happens? Initially there might be some improvement in the weakness and all these neurons develop and they develop these extra neurons. There will be neuron sprouts which will create new branches to compensate for the weakness. So the weakness might not be that predominant, but patient will still have some kind of weakness. But as they progress, decades later, what happens? These new motor units which had sprouted, they all become overworked and they got exhausted and they get degenerated, and that will cause a new onset of weakness. That's exactly what happened here. So this is how the post polio syndrome patients will be kept for you in exams. So they will come with the acute onset of weakness, okay, or worsening of the weakness. That happens because all these regenerated neurons, they become degenerated gradually, they become overworked, and they cause new muscle weakness, and it is not because of the polio virus. Okay, it's not because of the polio virus. Okay, it is because of the degeneration of the neurons. Okay, and how do they present? They present with new onset weakness, which can affect previously weaker muscles, or it can even affect the normal muscles as well. Okay, and this patient had a severe joint pain and muscle pain, isn't it? They present with severe joint and muscle pain. And one more important history was this patient also had a cold intolerance. Okay, so once the muscle becomes weak, they get more weaker in the colder environment. So in the winters, they might have even cold intolerance as well. Okay, don't assume that the patient might be having thyroid problem because of the cold intolerance. Okay, then they can be sleeping, they can be breathing or swallowing issues if it is a bulbar polio, and sleep problems if there is any respiratory muscle involvement. You ruled out this in your history, that was a good part. Okay, so always in such cases we need to rule out thyroid diseases, you'll rule out myopathy, you'll rule out neuropathy. Okay, now coming to the signs. Okay, what are the signs did you see here? One is limb discrepancy. Okay, you got it right. Then there was a muscle wasting. There was pes cavus, isn't it? There were hypopigmented patches. We'll talk about that. There was hypotonia. There was reduced reflexes. Power was 3 by 5 in left, 4 by 5 in the right. Plantars were downgoing or mute. Sensory intact coordination could not be assessed. Okay, right. So what pattern is this? This is the element pattern, isn't it? Element pattern with sensory or without sensory? Without sensory, right? No sensory involvement. So what are the differential diagnosis for element type of lesion without a sensory involvement? Yes, doctor. Dr. Supriya,
Yes,
what are the differentials, doctor?
spinal muscular atrophy, sir. Uh,
Mm-hmm.
conus cauda equina. Um, then peripheral neuropathy and CIDP versus GBS. Lead poisoning.
Okay, for this case, what will you give differentials?
Spinal muscular atrophy, sir.
What is your top most differential? The first differential should be post polio syndrome, isn't it?
Yes, sir.
Okay, then what is the next differential? What is the second differential, third differential, fourth differential, fifth differential? I would not put AIDP or CIDP here in the second differential. No. Then what else? Where do you localize the lesion?
The lesion can be localized to the nerves. Nerves. The
Nerves.
motor, yes, sir, or anterior horn cells otherwise.
Why would you localize to the nerves here?
Sorry, sir, anterior horn cells because only
Anterior horn.
motor is
Only motor
yes,
is
sir.
involved, so it is anterior horn cell.
Yes.
So what are your differentials?
Motor neuron disease.
Yes. Then
Um, Otherwise, multifocal motor neuropathy.
good.
Motor,
Then good. Then okay. So the right
nothing else
differential
is
here would be
systematic.
as it is LMN without sensory. Okay, with no involvement of sensory, all sensory modalities are normal and is asymmetrical. The first differential would be poliomyelitis. Okay, post polio syndrome, actually not poliomyelitis. Second differential would be motor neuron disease. Third differential would be your multifocal motor neuropathy. Fourth differential would be your spinal muscular atrophy. And then comes his fifth differential would be any anterior horn cell lesions. Okay, down the line I would tell peripheral nerve compressions. Okay, we'll come to that. So poliomyelitis, how would be the pattern? The pattern would be mostly proximal, more than the distal, legs more than the arms. If it has motor neuron disease, it is a PMA subtype, progressive muscular atrophy subtype, which will have a LMN signs only. Okay. What is multifocal motor neuropathy? Often they involve the upper limbs and compared to lower limbs. And it is an autoimmune condition. So you'll have evidence of any other autoimmune conditions in the patient. Okay, and it will have much more acute or subacute onset, unlike here. Okay, here the diagnosis is your post polio syndrome. Okay, the other differential based on the findings and based on the localization would be your motor neuron disease, would be your multifocal motor neuropathy, and SMA type 3 and 4, because 1 and 2 presents with element lesions from childhood. Okay, so 3 and 4 would be ideal here, and if it is childhood, then they'll have other ataxic features as well in this case, which was not there here. So SMA type 3 and 4 would be ideal differential. Then you got anterior horn cell lesions. What are the anterior horn cell lesions? It can be any of your spinal cord tumors or any radiation induced anterior horn cell damage, syringomyelia, and your anterior spinal artery occlusion. Okay, but you should know that syringomyelia will have sensory component involvement as well, right? Anterior spinal artery occlusion will have bilateral presentation. Okay, down the line you can tell about peripheral nerve compression involving the motor fascicles only. Okay, few of the peripheral nerve palsy, peripheral nerve involvement, palsy can present with only the motor component. That's very rare though, very rare. Okay, I would not put your yes, in acute motor neuropathy you can put your GBS, that is your AIDP and also CIDP, but they can have sensory as well, isn't it? They can have polyradiculopathy, radicular pain. Okay, if in general if anybody asks, in that case I could tell GBS as one of the differential, but for this case these would be the ideal differential. If you tell this top four also, that is more than enough. You can include the fifth if you want. Okay, these would be the ideal differential diagnosis. Okay, now coming to the hypopigmented patches. Why this patient had hypopigmented patches? If you see the distribution is very important. If you see the distribution, it is there in the left knee, it is there in the medial malleolus, it is there in the lateral malleolus, and it is there on the dorsum of the hands. What test you want to do when you get this hypopigmented patches? You want to check for the sensations, isn't it? What are the differentials here? Okay, one is, what are the differential for hypopigmented patches, doctor?
One is, sir,
Well,
vitiligo, leprosy,
yes,
sir.
leprosy,
Cancer.
right? Leprosy, vitiligo, right? Then,
burn, scarring,
okay. So one is your
Le-
leprosy, isn't it?
lesion,
Leprosy. Then
yes,
you
sir.
have got tinea versicolor, can present with hypopigmented patches, but there will be scaling in that. It can be post-inflammatory following a trauma or burns. It can be vitiligo. Okay, it's an autoimmune condition. It can be congenital. It can be due to nutritional deficiency like zinc deficiency, or it can be drug induced like your steroids or hydroquinone. Here, what do you think? What this patient has got? Somebody, Dr. KS told me that he has got vitiligo. which is an autoimmune conditions. Is your vitiligo autoimmune condition related to your post-polio syndrome, doctor?
So no, sir, both are different.
Both are different. So why do you think this patient has got vitiligo? Did you find any other autoimmune features in your patient?
Yeah, yes, sir. He's having anemia. Sorry, pallor is there, sir.
Okay.
So he might be having an autoimmune this pernicious anemia as a possibility, sir.
Okay. But it can be nutritional cause as well, isn't it?
Yes.
Okay. So what this patient had is, see, you need to ask him, how was your mobility? Were you able to walk? When he told you that he has got weakness, you have to ask him, were you able to walk? Okay. So this guy was crawling. Okay. So these young crawlers, what happens is there's a mechanical friction and pressure. Okay. So there's a repeated pressure on their knees, on their elbows, and other contact points. Okay. So this continuous friction can cause localized skin trauma. Okay. And that can, on the long run, it can lead to melanocyte damage, dysfunction, and there can be ischemia from the pressure, and there can be inflammation. So it was a post-inflammatory cause. Okay. Post-inflammatory inflammation, post-inflammatory hypopigmentation. Sorry. Okay. So that's what our patient had. So you have to always check for the sensation, because whenever you get hypopigmented patch in your exam, make sure you check for the sensation in those patch which you missed in the examination. Okay. Anesthetic patch, loss of sensation. If you get that, then you check for any thickening of the nerves. Okay. Not, and also look for any loss of hair and any loss of sweating. In that case, it can be a case of leprosy. Okay. So it is one of the good DD which you can give here. Okay. Vitiligo, yes, you can give. Okay. But the real reason why he had hypopigmented patch was because of this post-inflammatory hypopigmentation. Okay. Typical site for this is over the knees, over the elbows, over the forearms, and on the dorsum of the hands, exactly where he had them. Okay. Right. So that's covered. So what would be the management? What would be the management here? So physiotherapy. So you know what my examiner asked me in a neuro station, when I told him I would do a physiotherapy for my patient, I had a case of polio, actually poliomyelitis, in neurology station. What physiotherapy will you do, doctor? I did not answer him. I didn't know what physiotherapy. Here in NHS, once I came to the NHS, I came to know that you need to know what type of physiotherapy you need to advise to your patient. Okay, so in few cases, for few conditions, you might need intensive physiotherapy. For few patients, you need low intensity, non fatiguing exercises. The same one is advised even for motor neuron disease. I was wondering, why would an examiner ask me that question? I'm not a physiotherapist. How am I supposed to know it? But at least you need to know and advise. The physiotherapist would know, but they would expect you here in the NHS what type of physiotherapy. So you would advise the patient for low intensity, not fatiguing exercises, low graded exercises. Okay, that's the answer. Then you can give him some assistive devices. Okay, walking aids, proper pain control, manage his sleep and breathing problem if it is there. Okay, have a proper diet control, manage his weight. They might be malnourished, and refer them to the dietitian. And for the muscle pain and joint pain, advice for the warm environment. Okay. Before all this, you need to tell about this important point, that is patient education and counseling. Always, whenever you are dealing with a neuro station, always start your presentation with this point. First, I would educate and counsel the patient regarding the underlying condition. Only then you will tell about your management plan. Okay. This impresses your examiner. Okay. This shows them that you have understood the NHS system very well. Okay. This is the way how you would answer. Even you can follow the same technique even for your neurology clinical stations. Okay. I gave you unsatisfactory in the concerns, doctor, because at the end of consultation, the patient is unaware of his diagnosis. You did not tell me anything about how I'm going to do, whether this weakness will resolve or will it stay. Okay, will my dizziness, you are going to do anything for my dizziness? Will it stay or will it resolve? Is there anything I need to do for that? I was unaware of that. You did not educate me on that. You did not educate me anything in terms of your management plan well. Okay, you did not reassure me about any NHS support that I would need. When I have a chronic condition and which is going to stay with me for my whole life, I need to understand that I'm going to get the support from the NHS. So if you fail to do that, all this will go in your patient concerns. These are the questions that he might have been told by the examiners to ask you. So he can ask you only once you explain these things. So it is very important to explain the condition. What are you going to do? What are you going to do for his weakness? What are you going to do for his dizziness? What specific test you are going to do? Then you'll come back and speak to him regarding what's going on and the further plans. At least give him that plan and tell that you're not alone in this. We are here. We'll provide you all the support that you need. I can ask one of the brain doctors to come and see you soon. At least this much of reassurance has to be given to your patient. If you fail to do so, in few cases, we have seen the examiners cutting down the marks even in the clinical judgment as well. Okay. So this is something you have to consider. Okay. Again, a very important case, very common case for your exams. Okay. Polio is a very common case. You have to know in and out about poliomyelitis. Okay. You need to know the stages. You need to know the management. You need to know about post-polio syndrome. You need to know about the differential diagnosis. And you need to know how to counsel your patient. Okay.
Okay.
Here the patient had giddiness, not because of post-polio syndrome. Yes, there can be multiple reasons for his dizziness. It can be cardiac related. He had racing of his heartbeat. He had dizziness. He had got postural dizziness as well. So he might be evaluated further with an ECG and echo. That's one thing. And it can be because of anemia. Okay. Low hemoglobin. And yes, occupational therapy as well. Dr. Anusha got it right. So occupational therapy in terms of adjustment for his workplace, also at his home. Okay. Right. Any doubts? Any doubts from anyone?
Sir, the power is 4 by 5 in the opposite limb. Sir,
Yes.
like how to, sir,
Yes.
usually the patient like that, sir. Yeah.
So usually it will be asymmetrical weakness, isn't it, in polio? It starts with unilateral weakness, then it can become bilateral.
Okay. Sir.
So that's how the anterior horn cell diseases presents. Initially, almost 95% of them present with the unilateral weakness, asymmetrical weakness. Even motor neuron disease is always starts in one hand, then it goes to the other. Okay, that's a pattern in anterior horn cell involvement.
Okay. Sir.
Okay, you don't have to give the financial support here, doctor. They get the financial support. You can connect them to the social services and they will help them. Yes. Should we go to the communication? Anyone wants to do the communication from our group, from the November batch, other than Dr. Supriya? Okay, Dr. Aditya, would you want to do?
Yes, sir. Yes, right.
Okay. Just take the screenshot, doctor. Is it done?
Yes, sir.
Okay. So you can prepare, doctor. Once you're ready, we'll start.
Sir, I had a question regarding this case. Post-polio
Yes.
residual paralysis and post-polio syndrome, are they the same?
So post-polio residual paralysis, you get if it is beyond 6 months, it becomes permanent. Yes, they will have weakness. Okay, which will be like permanent weakness, but it will not be that severe. Post polio syndrome is when all these different nerves grows to support the muscles. Okay, so the more neurons develop and they support the muscles for the power. As they grow old, when they come in their 20s and their 30s, these nerves start getting degenerated and more weakness comes, and it can involve the previously weaker muscles or can also involve the normal muscles. So normal muscles also can start becoming weak. They can clinical stations, consultation, day 3 consultation, and communication. Right. And the offline course for this would start on the 1st of Jan. So, sorry, online course. So, as a part of offline course, you get access to even to the online course for the whole month, and you get to learn from all the other tutors. So, there are 5 to 6 faculty who will teach you. So, you get to learn from everyone. Okay. So, the registration would close before the end of this month, and the online course would start by the 1st of Jan. Once you're ready with this case, we'll start, doctor.
I'm ready. Hello, sir.
Yes, doctor, you can start.
Good afternoon. I'm Dr. Aditya. I'm the doctor in the wards today. Am I speaking to Miss Anne Brenneman?
Yes.
Hello, Miss Anne Brenneman. How may I address you?
You can call me Anne.
Are you comfortable? Do you need anyone along with you for this?
No.
Okay, Miss Anne. Miss Anne, can you tell me why you were in the hospital today?
Doctor, this is a follow-up appointment, and I see that I got this tummy problem, and I don't think any of the medications are helping me. I have tried various medications
Yes, Miss Anne.
now, but nothing seems to be working on me, and I'm really panicking now because I want a symptom-free life, and I can't be dealing with this my whole life.
That seems to be very difficult to deal with, Miss Anne. We'll see what we can do for you today. Can you tell me how you're doing currently? Like after you come to the hospital currently, have you been doing after that your previous admission?
Not great.
You're not been doing so great. I'm sure it must be difficult. I can we'll see what we can do for you, Miss Anne. So you've been diagnosed with this problem how long ago, Miss Anne? Your tummy problem, and were you on any medications for this?
Yes, I had, like I told you, doctor, I had tried various medications
Yes. Okay. And how long have you been using these medications for now?
since 4 years.
Okay, okay, Miss Khan. So, like you said, the tummy problem is something that has been going on for a long time, and the medications that you've been using are not controlling the condition as well as we would hope to. So, you have a condition called ulcerative colitis. So, what happens is in this condition, basically your bowels are slightly inflamed. So there are, if I have to tell it in a more easy manner, your gut, your bowels are not working as well as they should, because there are some wounds in your bowel. So that is the reason why you're having all the symptoms that you seem to be having. And after your previous admission, our team of surgical gastroenterologists went through your whole case and went through the entire details and have come to a decision. Uh, and it is a little difficult. Would you want me to continue, Masan?
Mm-hmm.
Yes. So they are suggesting that the the whole team, we are thinking that your condition seems to be a little advanced, or it is slightly getting a little difficult to control with all the medications, because it's the condition is quite advanced and you would require a surgery for this.
I would require a surgery.
Yes, Miss Anne. I'm sure it's very difficult to
So,
hear.
so we are done with all the options in terms of the
Yes, Miss Anne.
medications.
So
I was not expecting that I have to undergo a surgery for this.
I understand, Miss Anne. I know this is
I don't want to
some.
undergo a surgery, doctor.
I know.
I just came here to see if there's any other options, if anything else can be done. Surgery is not something which was on my mind.
I understand, Miss Anne. And as you already know, you have had some fair amount of admissions because of your tummy problems, and we've tried our best to do deal with these admissions in with medications and injections that we can try and give it to you. But like you said, you're not been feeling so well even after doing all of these medications and tablets that we have given you. And based on the previous admission and all your reports, it does seem like you would do better with a surgery.
Okay.
So, would you like me to tell you more about the details of the surgery?
But I would still want to try some other medications.
I
Because
understand, Mr.
surgery is a big thing. It would affect my day-to-day life. It would affect my job. And
Yes,
what
Mr.
surgery is it?
Sorry.
What surgery is it?
Yes. So if you would like to if you would like, I can go ahead and tell you more about the details of this surgery.
Mm-hmm.
So with this surgery, it is called panproctocolectomy. It seems a little complicated, but basically we would take the most of your affected part of your bowel out and make and then give a new pathway for for the waste from your body to come out. So this sounds very complicated, but this is something that is done quite commonly for such conditions. And this would require a surgical gastroenterologist for the surgery. And we would do something called an ileostomy. An ileostomy is basically, if you can see in this diagram, in this bowel, we'll be removing this parts from the, this is what they call a colon to the anal region. We'll be removing this part and giving a different pathway for all the waste that your body is going to put out. So you will have a opening on in your abdomen, which you will need to maintain, which we will tell you how to maintain it, and we will give you all the necessary training and also the necessary leaflets and all the information that is necessary for you to know. But this is something that we will be planning to do. And after we do this, there will be some changes to your lifestyle as well, but you will be able to go back to a normal lifestyle. So you will need to be conscious about how you have your food, what sort of food you have, and you will need to be on some certain supplements so that you don't develop any deficiencies of the any deficiencies that might be there, that might cause because we have removed a part of your bowel. And this is quite necessary because if we do not do this procedure right now, and if we still take a conservative line of management, there is a possibility that you will still be having these symptoms, and these symptoms might worsen more and might affect your quality of life. But if you do the surgery, there is the chances are that you will be able to go back to your regular life and your job, and be relieved of all of these symptoms that you're currently experiencing. And we can there will be support for you from our side post the surgery. And if you have any other information, if you require any other information, and and if you would like to speak to our senior consultant as well, we can arrange that in the next appointment as well. And we will let you know, and we will give you the further information whatever you require, with all the leaflets in it while you're leaving. Do you have any other questions, Miss Anne?
No, I'll have to think about this, doctor.
You don't have to uh, give me an answer straight away, but you can think about it, and you can get back to us. You can discuss with the family, and you can get back to us with an answer. So this would be the best way to move forward. And if you have any questions, or if you would like to discuss more doubts, or if you have any other concerns, we are happy to answer them for you.
Okay.
Anything else that you would like for me to answer, Ms. Anne?
No, doctor.
Okay, so just to summarize, your condition is called something called ulcerative colitis. It is quite advanced in this current moment, and the medications that you are on currently are not maintaining as well as we maintaining your symptoms as well as we would like to. So the suggestion from our side is now to go forward with a surgery called panproctocolectomy, which would leave you with something called an ileostomy, a pathway for the waste to come out, which you will require some maintenance for that. And you will need to do some lifestyle changes, and you will need some supplements going forward. Anything else that you would like to know, Miss Anne, at this current moment?
No, doctor. Okay. Your time ends here.
Yes.
Just give me a second, doctor. Yes, doctor. So you have done well, but you're using a lot of jargons, gastroenterologist, colon. These all are jargons, and you need to avoid those.
Okay, sir.
Okay. And see, first is you need to check the understanding and how much these symptoms have impacted her day-to-day life. You need to understand how much her symptoms are controlled, how much medication is she taking currently, right? So these are very important. Without that, it would be difficult to counsel her for the surgery, because surgery would be the next big thing, isn't it, for her? It would have a lot of changes in her life. So to avoid that, you need to develop a rapport with your patient. Okay, ask her if she has have done any changes in her medication recently. Has she had done regular follow up with the doctors? How is her day to day life? Okay, and does she need any support with that? How is her job? Any impact in her personal life? So show empathy and build a rapport before you break this news about surgery. Then know the past medical history, drug history, okay, personal history, okay, about smoking, alcohol, very important. Okay, once you know that, then you got to explain her the reason for her symptoms. That she has got this condition called as ulcerative colitis, which is a soreness in her tummy, and for quite some time now that she's suffering with all these symptoms, and you understand how exhausting and frustrating it can be for her, because you have tried all your efforts, you have done everything that she her symptoms can be well controlled, but unfortunately that has not happened. So usually what do you try for ulcerative colitis? You go for 5 minutes salicylic acid, then you go for steroids, then you go for immunomodulators, then you go for biologics. So all this medication would have been tried in her, isn't it? And so what you can say is, unfortunately, even after trying all these medications, including the strongest available option, your body has not responded. And continued soreness in your bowel not only causes these symptoms, but also puts you at risk of developing some serious conditions like damage to your colon further, and can increase the risk of cancer as well. So for this reason, at this stage, we are considering something, a form of treatment that would give a permanent relief for you from your symptoms. That is removal of a part of your colon and your rectum or your back passage. This offers the best chance of stopping the symptoms from coming back, reducing the risk of long term complications, improving your quality of life, which is very important currently for you. I know that this would be a big thing. What we do here is we simply remove the gut tubes, and a part of your gut tube will be connected to an external bag, and we'll train you how to use the bag frequently later. Right now, what I want you to understand is why we are thinking of this surgery and what support you will have for this. We do not take the decision lightly. We have explored and exhausted all the medication options, and this is the next best recommended step for you. Okay? Then you will explain the other things, like the surgeon will come, okay, and give you more explanation regarding the procedure or the surgery. I'll give you a specialist nurse contact who will be available to support you emotionally through this journey. The nurses will train you how to use the external bags. We'll have a dietitian on board who will guide you on your proper nutrition. We'll have a physiotherapist who will support you for the mobility following the surgery. And we'll have a mood doctor to support you emotionally through this. Even after the surgery, you will still be under our care, and we'll still follow you up for you to provide a better support. You can live a life not worrying about the symptoms, not worrying about the side effect of medications, and not worrying about rushing to the toilet. With the right support, most of our patients have done extremely well, and you can also benefit from this. I know this is a big decision. You can go back, discuss with your family, and get back to us. Meanwhile, I'll share you the leaflet. I'll share you some video on your smartphone. You can go through it to understand what the surgery is. Okay?
Okay.
Okay?
Okay.
You have done well, but again, the same thing can be done in a different way.
Okay.
Okay?
Okay, sir.
Any doubts?
No, sir. Sir, generally, when we are discussing such communication cases and we are talking about the support part of it, for example, in this patient,
Mm-hmm.
we are talking about the support part of it. Is there any particular link that we can see where for NHS levels, anything that we can follow for the like?
Okay, I'll share it to you, doctor, in the group. I'll share it to you.
Yes, sir.
Okay?
Yes, sir.
Fine. Any doubts? Anything else? All right, I have got a meeting at 3 p.m. here. I've got 5 minutes to left. So if there are no doubts, we'll just end the session.
Okay.
Okay. All right, fine. Thank you. Thank you. Thank you everyone for attending the session. Please do drop your reviews in the group. Okay. Thank you, and see you in the next session.
Thank you, sir.